It truly is an honor and a privilege to be invited to speak today as we commemorate Black Maternal Health Week. I'm Dr. Heather Rice. I am a professor here at Cleveland State University in the College of Health. I'm also a clinician, I'm a pediatric nurse practitioner, and I'm a child and maternal health researcher. My work has focused primarily on community-centered research interventions, and I've had the honor of working with 3 of the organizations that you heard earlier today. So that's the Village of Healing Center, Pregnant with Possibilities Resource Center, and Birthing Beautiful Communities. Black Maternal Health Week is not just a time for awareness, but a call to dismantle the structural inequities that disproportionately affect Black mothers and their babies. We cannot ignore the stark reality that Black women in the United States are 3 to 4 times more likely to die from pregnancy-related complications than Caucasian women, and 80% of these pregnancy-related deaths are for preventable reasons. The mortality rate for Black women who have completed a college education is 5.2 times higher than the rate for white women with the same educational attainment, and 1.6 times higher than the rate for white women with less than a high school education. Therefore, when we look for policies, practice guidelines, and research solutions that holistically address this issue, no Black woman can be left behind. Opportunities in practice abound by integrating cultural competence and cultural humility into maternal health care and training, expanding access to prenatal care as well as mental health services, aligning with our findings that Pregnant with Possibilities evaluation, we found the need for innovative and creative models of social support and prenatal education. We must also confront the uncomfortable truth that medical racism is a stain on our healthcare system, and the inequities experienced by Black women are not due to any inherent biological differences, but rather a result of deep-rooted systemic racism, discrimination, implicit bias, and lack of access to quality healthcare and support services. Diversifying the healthcare workforce helps to work towards a more inclusive and representative health system that meets the diverse and complex needs of our patients. The need for Black providers has been discussed in medical practice. It's paramount to addressing these long-standing disparities in healthcare. This is also the focus of our research at the Village of Healing Center, because research suggests that having more Black providers can improve cultural understanding and trust, and improve communication between the patient and healthcare provider. Research has shown correlations, including reduction in infant mortality rates, increased patient adherence to healthcare guidelines, higher patient satisfaction, and improved patient processing of healthcare information. These findings illuminate the subtle ways that race affects how patients and providers communicate, make treatment decisions, and bring subconscious racial perceptions to the medical room, regardless of either person's intent. In addition to racial concordance, investing in community-based care models such as midwifery-led care and community perinatal doula support has also been shown to improve maternal health outcomes. Our research at Birthing Beautiful Communities has found that doulas offer invaluable support and guidance to expectant mothers. They enhance birth experiences for Black mothers, ensuring that they feel seen, heard, respected, and empowered throughout their pregnancy journey. Doulas provide emotional, physical, and informational support, serving as advocates as well as translators of medical jargon. The Black doula midwife care model can lead to fewer C-sections, fewer preterm births, less use of pain medications during labor, shorter labor times, increased breastfeeding initiation, lower healthcare costs, and more positive childbirth experiences. In Dr. Cooper's powerful book, Medical Bondage, Race, Gender, and Origins of American Gynecology, she explored the forgotten history of Black women's bodies being subjected to medical exploitation and torture in the name of scientific progress. This book delves into the dark history of American medicine, shedding light on the aspect of a past that many would rather forget. I would be remiss to speak during Black Maternal Health Week and not acknowledge the women pictured behind me. The Mothers of Gynecology Monument in Montgomery, Alabama honors 3 of the women, Anarcha, Betsy, and Lucy, who we know were tortured at the hands of J. Marion Sims. The statute incorporates meaningful yet powerful symbolism of a legacy of medical racism that continues to impact medical care, particularly obstetrics. Addressing these root causes is crucial for effective solutions in Black maternal health research, policy, and practice. Advocating for policies to dismantle the systemic barriers and support community-based interventions is essential. A comprehensive integrated approach can mitigate disparities in Black maternal health and foster a healthcare system prioritizing equity, collaboration, and holistic well-being for all women. I thank you all for your attention today. It is truly inspiring to see you all gathering and finding value in this topic. It is so important. Please continue those conversations when you leave today. Thank you. I need your help. Listen.
Jaleesa, I hit something. No, I didn't. It all worked out. Hi, everyone. It's so great to be here today. Thank you to Jaleesa for coordinating this fantastic event and extending an opportunity for us to be here today. My name is Shannon Walker, and I'm a postdoctoral fellow over at Case Western Reserve University. My research broadly focuses on the social conditions in our environment and how those are drivers to inequitable health outcomes in our communities, and specifically the food environment. So I wanted to take a second today to talk about food access and its relationship with Black maternal health equity. So as we know, in Cuyahoga County, particularly Black women are disproportionately burdened by poor maternal and infant outcomes. If we look at recent data over the past few years, we can see that Black women in the county experience maternal mortality at a rate 2.5 that of white women. Black babies make up 35% of all births in the county, but make up over 59% of all infant deaths. And preterm birth, a known risk factor for infant mortality, affects Black babies more than babies of any other racial group in the county. And so in talking about these disparities, it's critical to account for and address the social determinants of health, which we touched on a bit here today, but I want to expound a little bit more. So social determinants are non-medical factors that influence health outcomes. They are the conditions under the environment that we are born, grow, work, live, and age that includes things like housing, food security, and healthcare access. Oftentimes, when we're talking about our zip codes being a bigger driver in our health outcomes than any other clinical factor, this is what we're referring to. And these are especially important because our social determinants drive over 80% of a person's health outcomes. And that is over and above the contribution of healthcare. As you can see, that comprises only about 20% of a person's health outcomes and health status, compared to things like your socioeconomic factors, your physical environment, and your health behaviors. And food security is a critically important social determinant of health, particularly relevant prenatally, pregnancy, and postpartum. And food insecurity is the lack of consistent access to enough food to meet basic needs. And in Cuyahoga County, we see racial disparities here as well, where about a quarter of all Black households in the county experience are food insecure compared to only 10% of white households in the county. And so limited access to nutrient-rich foods during pregnancy increases the risk for poor maternal and infant outcomes that can be short and long-term. These include things like increased risk of developing gestational diabetes, anemia, high blood pressure, low birth weight, and birth deficits, as well as poor development and behavioral outcomes that persist throughout the life course of the infant. And so in thinking about these disparities, changing course may seem daunting, but there are strategies to move us ahead towards a more equitable society that I'd like to just touch on briefly. First and foremost are the community organizations, a bunch of whom that we've heard today on the earlier panel. These organizations are essential at meeting individuals and communities where they are and providing food or other material support. These organizations are dedicated to increasing food access via farmers markets or urban agriculture, as well as organizations that provide wraparound services for patients in need. These organizations exist, and it's important that we show our support through our service. One such organization that I'm proud to be affiliated with is Pregnant with Possibilities Resource Center that we heard from today, the CEO, Veranda. And so they provide a host of services at no expense, particularly to those who are pregnant and postpartum. Another avenue is academic partnerships through research. Research is critical to the design and the evaluation of interventions that ultimately go forth to inform policy decisions. And it's also important that we talk about this in the context of Black women and Black people as a whole, who we know are disproportionately underrepresented in research opportunities. We can't be a part of the solutions if we're not at the table. And so some of these studies, like food as medicine programs, provide produce prescriptions or medically tailored meals and groceries that provide services for patients with high medical need in order to treat diabetes diagnosis or manage hypertension. And again, research is critical to advocate for data-driven, informed, equitable policy change. And then lastly, again, the data-driven policy. That's big P policy or small p policy to provide sustained systems and structural change. Just a few quick examples. In this space, particularly relevant is passing the revised Farm Bill, is a piece of legislation in Congress that gets put forth every 5 years. One of the biggest components of that in this context is that it decides how much money gets allotted to SNAP. And that's particularly relevant as we know how inflated food costs have been post-COVID. And we won't see those adjustments in SNAP benefits until we see a revised Farm Bill. Another is community-driven food procurement policies. So the food here was great today, but oftentimes in these settings, the food is provided or purchased through companies like Cisco or Airmark. And if we can commit to supporting local food systems and local food growers, we can see cyclical economic growth, not just in consumers, but also in the growers in agriculture. Expanded nutrition assistance programs. During COVID, we saw the successes in dropping household and youth food insecurity with the expanded SNAP program allotments, but then the dollars dry up. And then we're back almost where we started. And then again, community food systems development. So things like local agriculture and identified community-based interventions to expand access to nutrient-rich, culturally relevant, desired, affordable food for moms, babies, and the family holistically. All right, that's my time. Here's my email, so feel free to contact with any additional questions. Thanks.
Just one moment trying to look for my PowerPoint. Okay. Okay, so hi everyone. My name is Natasha Teshi-Micah from the Center for Community Solutions, and I am a Public Policy and External Affairs Associate. Here's my contact information if you have any questions in the future. And for those of you who haven't heard about the Center for Community Solutions, we are a nonprofit, nonpartisan think tank that focuses on improving health, social, and economic conditions through nonpartisan research, policy analysis, communications, and advocacy. So let's just jump right into the challenges in this space. We all know that Black mothers are dying at high rates. In Ohio, Black women are 5 times more likely to die from pregnancy-related deaths. than the state average. And the leading causes of pregnancy-related deaths in Ohio for Black women are preeclampsia, eclampsia, cardiovascular, and coronary conditions. And I put this stat here about maternal mental health because it is becoming a rising issue. 40% of Black mothers and birthing parents struggle with maternal mental health conditions. As we can see in Cuyahoga County between 2008 and 2016, 65 mothers passed away, unfortunately, due to pregnancy-associated deaths. And as you can see here, more Black mothers died than white mothers. Now, racism is a major driver that propels maternal deaths. And when you think of racism, you can think of many concepts, but I listed two. One of them is medical bias. And that happens when there is disparate care for medical professionals due to implicit biases. So, for example, during medical school, students will think that Black women are able to withstand pain more than white women, and that's taken into practice in the prenatal appointments and doing labor and delivery. They will ignore the Black woman's complaints about the aches and pains, and that will lead to unnecessary health complications. Another concept is weathering. So that happens when a person is constantly experiencing discrimination, racism, and stress. And over time, that will lead to premature aging in the body and negative health outcomes. So here are the consequences of weathering. As you can see, some of them actually relates to the causes of pregnancy-related deaths, such as hypertension and mental health conditions. So there are gaps in this area. The first one is there is not enough timely disaggregated data by race for maternal mortality and morbidity. As I mentioned a few slides back, there were some data that was about 6 to 8 years old, so there has to be some advocacy done around this space. The second point is convincing legislators who don't usually understand maternal health issues. Sometimes many of the legislators who come into the State House have their own priorities in mind, such as supporting small businesses or taxes, so they don't really know what's going on in maternal health in their district. So it's important to educate them when you are interacting with them. So here are the opportunities. First one is doula Medicaid coverage, and luckily, thanks to the state budget last year, doulas will be reimbursed through Medicaid. There is currently a doula advisory board that's under the Board of Nursing, and the Board of Nursing will implement rules for certifying doulas. Public comment happened a few weeks ago, but there's another opportunity to provide comments or testimony during the Joint Committee on Agency Rule. Another bill to look out for is House Bill 7, which is the Enact the Strong Foundations Act. It focuses on the child's first 1,000 days of life. However, it also provide wraparound services for the child and parents. So they are trying to increase funding for healthy beginnings at home, which focuses on access to housing and rental assistance. Move to Prosper is similar to Healthy Beginnings at Home. And then as far as WIC is concerned, there are efforts to just try to increase telehealth or video calls for the clients when they try to reach out to WIC. There are opportunities to testify for this soon. It's stalled in the House at the state, but there has been a few hearings over the last year. And the last thing you can do is you can advocate and use our fact sheets. So at Community Solutions, we have fact sheets based on different districts, based on the status in women's and even Cleveland neighborhoods that pretty much give you details about the demographics of that community. You also see some information about Medicaid, Social Security, and also just some information about maternal health. So I encourage you all to just go onto our website at communitysolutions.com and look out for our fact sheets. And here is our contact information. Again, if you want to learn more about us, you can go on our website at communitysolutions.com. We have a weekly newsletter called 5 Things You Need to Know, and then you can follow us on social media. All right, thank you so much.
Good afternoon, everyone. My name is Pete Hake, and I stand before you this morning from having come from Toledo. But in my professional life, I spend my career listening to Michigan mothers. And although one of our states clearly has a lot to show the other state when it comes to quality of college football, I'm not going to say who needs to learn from whom, but on such an important matter as maternal health equity, we are all on the same page and pulling in the same direction. So indulge me for a moment as I share. With more time, I think I could have picked a statement from everybody that's spoken today and assembled all the things I had been planning to say anyhow. But here we go with my take on these words. Although if I could take Dr. Rice's comment that medical inequities are a stain on our health system. That's another alternate title for the little story I'm about to share with you. And I'm here from we're called the Pregnancy Risk Assessment Monitoring System. It's an ongoing survey of maternal and child health. Just about every state has one. Ohio has had a PRAMS for quite a while. There's a PEAT in Ohio, but they're running their own survey now. So anywho, we're going to look together at how common is race-related mistreatment when receiving pregnancy health care in Michigan between 2016 and 2021. Time is short, so I'm skipping over the how and the why of the survey, but suffice to say that we do random selection on those who had a live birth in the state. We start with loads of paper surveys and phone calls, and after a couple years of hard work, those are transformed into a database, and within this database is contained the collective stories for a given birth year for the population of Michigan mothers. And we're going to look at one experience in particular, a question to which nobody should have to answer, yes, that's something that I experienced. And the survey question for today is, during the 12 months before your new baby was born, how often did you feel that when you went to get healthcare, you were treated worse than people of other races or cultures? And again, everybody should be checking never, but that's not the case. 92% of moms get to check never. About 6% of moms say that this was sometimes an experience they had, and this is during the year before their baby was born, so it contains the entirety of prenatal care and probably labor and delivery, depending on how you read it. 1% say this usually happened to them, another 1% say that this always happened to them. And again, this should be 100% saying no. Nobody should be able to say yes to this. Perhaps one of the most obvious ways to break down that information is by how mom looks. How is she treated during this time frame by the healthcare system, by race, ethnicity? And combining all of those ever experienced this into one, we get just about 8% of Michigan moms who say that this was something they experienced. And so that's 1 in 13. 4% of white moms say that this was an experience they had. And compared to that, every other non-white group of mothers in Michigan is much more likely to report race-based mistreatment when receiving health care in the time around pregnancy. That's ranging from twice as common to 4 to 5 times as common. And we have, nobody should have to earn equal treatment or good treatment, especially not in a healthcare system. And people in this room are acutely aware that society is really comfortable with telling moms how and when they should be doing things. And if you will, that can be condensed down into something of a playbook. If you want to be a successful parent, you should not have your kids too early. You should complete some schooling. You should get some good private insurance, and you should have a good job, and you should have these kids in the context of a marriage. These are not my rules. This is what, if society was dictating what they think moms should be doing to be successful parents. And wouldn't you know it, that same playbook that operates for how people should be having their families, again, not me saying that, society, It relates to one's risk of being mistreated in the healthcare system. As mom's age goes up, risk of mistreatment goes down. As education goes up, risk of mistreatment goes down, but according to the kind of insurance that somebody has, according to marital status, household income, and some aggregate measure that I won't go into now. If we look at how the healthcare system is treating moms based on this playbook. Oh, sorry, wrong note. So the takeaway from this slide is that social capital can somehow prove protective from being mistreated while receiving health care. Does that playbook operate in the same way for non-Hispanic white mothers in Michigan as it does for Black mothers in Michigan? And for those who don't feel motivated or moved by graphs, here's a quote from an individual PRAMS respondent. They were definitely mistreated, and this mom knew that it was because of her race. So again, if we look at the social capital playbook, I guess, it turns out that if white mothers are following that rule book, then they can reduce their risk of being mistreated in the healthcare system based on their age, based on their education, based on their insurance, based on marital status. Their family can earn their way towards better treatment in a healthcare system. And again, this is home visiting eligibility. People don't like telling us how much they earn, but if I condense my most available information into one variable, it's there. And here's where I would pull in a direct quote from Dr. Cooper Owens, that none of the factors that serve to confer, none of the social determinants of health or none of the social capital factors that serve to provide protection for white women in this setting and with this experience function for Black mothers. And that's exactly what we've seen in Michigan. That as maternal age increases, not only is there no protection, but there's probably an increased risk of mistreatment for Black mothers following the playbook. The same with education. There's no protection to be found based on the kind of insurance that mom has within the healthcare system. There's no protection to be had by marital status. And Black mothers following this playbook, which cannot earn their way towards better treatment. The risk of mistreatment in a healthcare system for Black mothers seems to be increasing as social capital increases for this group. And that doesn't seem like much of a fair playbook. It seems more like a trap. So this is brand new news out of Michigan, but scholars and people in the field have been seeing things like this, but you're hearing this right now from Michigan moms as well. And then, I'll go back. I saw someone about to take a photo. I'll tell you that for the final graph I'm going to show you, if you're about to drink some water, set it down because it's alarming. Lest you, oh my goodness, what's happening? This person shares that the hospital they went to was the worst. They didn't ask her the right questions. They saw she was Black. They started filling in information. They need to work on racism and kindness. They completely lack kindness. So looking at across 6 relatively short years, are things at least getting better for Black mothers in Michigan with race-based mistreatment? This person hopes that there's a positive change for the healthcare of African American women in the hospitals, and I'm afraid there has not been. We've gone from 1 in 9 Michigan moms reporting this experience. Again, it should be 0. Black moms in Michigan. It's more than doubled. In 6 short years, we're at the point where 1 in 4 Black mothers in Michigan are reporting race-based mistreatment when receiving health care. And there's no change for the white mothers in Michigan. It's a steady state. All right, I'm sure I'm over time, and I'm going to skip quickly through my employer-mandated closing slide, but I will I will call out either me or your state or locality might have someone like me. None of us own this information. It belongs to all of us. And I believe it was given to us, it was shared with us with the belief that we would then share it with people in rooms like this. And so please get in touch with either me or somebody in your locality that works on prams, and let's make some nouns into verbs. Thank you.
Hello, my name is Ladia Eccles. I represent Anthem with just part of Evelyn's Health. Now, let's see. You said I can just, my slide isn't coming. You said first word? Oh, shoot. Okay. And I can just skip over and use using my mouse. Okay. Yep. All righty. So the question was asked earlier, what are health insurance doing? So Anthem, which is Evelyn's Health, will invest up to $30 million over the next 3 years to support programs that ensure pregnant people and their babies can achieve optimal health and well-being. I'm not going to read through every slide. This is what we are pledging to do over the next 3 years, which is, I think, $5.6 million. We're working closely with a couple of foundations here. Please excuse me while I get everything together. Oh, shoot. Including the March of Dimes. Now, Kent State and Birth and Beautiful Communities. We've pledged money to them as well. Centers for Children and Family. So I'm going to tell you exactly what it is that I do. I work primarily with the PRAF program. So what is the PRAF program? That is the pregnancy risk assessment. So what that does is that is Ohio Medicaid's preferred methods for providers to notify the state and contact MCOs of an individual's pregnancy. So every time we get someone pregnant that comes in, I review it and I send it out to our staff to outreach these members, no matter what their pregnancy level is, whatever their beginning, if they're at the end, whatever. Soon as we get a claim that this person is pregnant, we send someone out to outreach this member as community health worker, a care guide, or a case manager. All righty. Anthem utilizes Ohio Department of Health infant mortality data zip code, and our Director of Healthcare Management has developed a process whereas maternal members living in those communities are deemed high risk. All pregnant members are outreached and provided value-added benefits and other case management. We provide digital concierge care that offers a 10% increase in engagement tracking of food, diaries, kit counts to assist our mothers, and maternal health support for 60 days, about 2 months postpartum. Face-to-face visits, telephonic case management postpartum, for our postpartum programs following our moms, and case management for 1 year postpartum delivery. Okay. We have collaborated with Birth and Beautiful Communities and Pregnant with Possibilities for several community events, including health fair, health showers, baby showers, and other events that they have put together for women that they serve. We have established post-directional referrals through Find Help to receive referrals for our New Babies, New Lives CM programs, and to refer our members to these organizations. The referral programs allows for closed loop referrals and tracking of collaborative outcomes. So I'm pretty sure y'all don't want to read all of these slides, but this is it. So this is what we're doing on this end, is making sure that we're pledging this money and providing these grants to these programs and these within the communities and organizations to provide care and assistance to our moms. All righty. Thank you.
All right, everyone, we're going to close out our wonderful afternoon. I still hear a lot of vibrant conversation and excitement
The enthusiasm is infectious, so we love it, and we hope that you'll bottle it up and take it with you as you head to your jobs and families. So one favor, if you would please complete the evaluation for today's event. It's on page 19 of your program. We ask that you do that no later than Friday, April 21st. But we're not asking for something for nothing. There are a couple of items that you can win: a family membership to the Cleveland Metro Park Zoo, a 60-minute massage from the Womb Wellness Center, a voucher for up to 6 concert tickets from Music Box Supper Club, and 2 tickets to the Vintage Ohio Wine Fest. So you'll be prompted to enter that raffle after you complete your evaluation, and this will help us build that case to have this event year after year. So thank you so much for doing that. What's next? So we have the Ready, Set, Brace pilot. We'll tell you more about this in a follow-up email. We want to respect your time, but there will be an opportunity to engage with faculty, community, and use Metro Health's Building Research for Academic and Community Equity Toolkit, so you can get primed and ready to go to, launch your research project. You can become a member of the CTSC. Visit us at www.case.edu/medicine/CTSC. And we have some events. You see them all in the program, though, so I will not read them. But we thank you so much for joining us, and this could not have been a better afternoon. So have safe travels, and thank you, thank you, thank you.